Vasopressin analogues. Just to start with, disclosures and acknowledgements are shown here. So when invited to talk on this, the plan I was given to say review the mechanisms of action of vasopressin analogues, discuss the evidence behind their use, and then finish with some practical aspects about how you might want to use them in your clinical practice. So we'll start with some basic physiology. As a reminder, vasopressin is a small nonapeptide secreted from the posterior pituitary, synthesized in the hypothalamus. It's a hormone with two actions and two names. It is antidiuretic hormone, and in health, when you're sitting here, it's involved in osmoregulation, hanging on to water, binding to V2 receptors in the distal convoluted tubule of the kidney. But in shock states, levels go up and it acts as a powerful vasoconstrictor. And this time its action is through binding to V1A receptors on the vascular smooth muscle. And people are particularly interested in using vasopressin in septic shock because a relative vasopressin deficiency has been described. So an old paper now, but when compared patients with cardiogenic shock to septic shock, although they had the same levels of hypotension, you see the septic shock patients had what would appear actually sort of very normal physiological levels, not the higher levels. This has been looked at in more detail by Tarek Shasha and working with Jalali and Nunn, who's looked at it in more detail, and you can see that in all these patients it's dropping over time over the first few days, and in some patients it's dropping very early. So you get this relative vasopressin deficiency. As to how it works, if you want to read about binding to the family of vasopressin receptors, you can read this great review by Lucinda Barrett and Mervyn Singer from just over a decade ago. The important message is it's causing vasoconstriction by working through non-catecholamine pathways, and it therefore spares catecholamine use. So this is a small trial in Canada, proof of concept, where they added in a blinded infusion of vasopressin. The nursing staff were told to keep the same blood pressure, and you could see they were able to turn down the open-label noradrenaline that the patients were already on. So it works as a vasoconstrictor. And in this review, we looked at the different receptors it binds to. I said there's a family of vasopressin receptors. The V1A is what's causing the vasoconstriction. There are also receptors of platelets. People are concerned about platelet aggregation. Is that a problem? There's V1B. There's previously also been called V3, which may be involved in ACTH release, prolactin release, and the anterior pituitary. I'm not sure we know the clinical significance, really, of these receptors in sepsis. But then there's the V2 receptors, which are talked about already, involved in water reabsorption. And I'll come back later to their effect on whether they release von Willebrand factor, factor 8. But there is some evidence that they may be involved in selective vasodilatation. So if you go back to that review article, if you look at it, what you see is that in some endothelial beds, the V2 receptor and in fact the oxytocin receptor, which is obviously the other posterior pituitary hormone, vasopressin, can bind to that, and it can bring about some vasodilatation in certain vascular beds. Maybe that's a good thing. Maybe in the coronary circulation, that might be good to maintain coronary perfusion. Or is it dropping blood pressure? So as I said, we'll come back to that idea. But the heterogeneity of these receptors is important even with just the V1A receptors, where there are more of these receptors on the renal efferent than the afferent arterioles. And the hypothesis is that, therefore, you would get more constriction of the efferent than the afferent arterioles, and that might maintain renal perfusion better if you use this as a vasoconstrictor. Whereas if you compare it to adrenoreceptors, which are equally distributed, you might reduce renal blood flow, at least in physiological experiments. What happens at the bedside? Well, again, that same proof of concept study that put up before, where we reduced the catecholamines with the same blood pressure. These patients had the same blood pressure, but that 4-hour infusion led to a urine output increase for the same blood pressure. So maybe it is having an effect. There are other studies have shown similar effects in the kidney. So again, this other small trial, similar number of patients, 23 patients, giving vasopressin very early, within the first 12 hours, and going up to very high doses, you'll note, up to 0.2 units per minute, actually saw an improvement in creatinine clearance when they gave it this time over a 48-hour period. But these are sort of still physiological endpoints. What about patient-centered outcomes? Well, You'll be familiar with the VAS trial. Nearly 800 patients established septic shock who were randomized to vasopressin up to 0.03 units per minute compared to norepinephrine up to 15 mics per minute. And there was no difference in the primary outcome, which was 28-day mortality, shown by the dotted line. But as you see, maybe by day 90, there's maybe a trend to an improved outcome in the vasopressin-treated patients. But interestingly, when we looked at the hemodynamics of these patients, there was quite a marked reduction in heart rate in the vasopressin-treated patients. And I know the next talk is talking about beta blockers, so I sort of mention it here. There was this reduction in heart rate, which maybe is beneficial. And interestingly, with that subgroup analysis that was planned in the VAS trial, again, you'll be familiar with this, where the less severe shock patients on less than 15 mics per minute at baseline, they were the ones who seemed to benefit, whereas if you were on the higher doses, more than 15 mics, there was absolutely no difference in outcome. And when you look at the hemodynamics, that heart rate effect is really pronounced in that less severe shock group. Is that why the benefit was seen? I don't know, or was it just an association? How did it happen? Well, maybe, again, if you're on less norepinephrine, you substituted, got more off, and you actually proportionally got rid of more of potentially the beta agonist effect, that although we think of norepinephrine as an alpha agonist, it does have beta effects, and we were able to reduce that. And maybe this reduction in heart rate by reducing catecholamines could be beneficial for our patients. So, is there any other explanation for why we saw these subgroup results? Well, of course, it could just be a chance effect, and certainly that's why we thought we needed more trials. But maybe these less severe shock patients are just earlier in their disease process, and they haven't gone up to such high doses. You need to get in early. And there was some evidence we had that maybe it was vasopressin might prevent renal failure from developing rather than having any effect once it was already established. Or maybe just the more severe shock patients were more ill and they needed more pressor and they needed more vasopressin. So maybe we should go up to a higher dose than the 0.03. And that was the rationale behind our VANISH trial published in JAMA a couple of years ago, where we tried to intervene early. We said we wanted to give vasopressin ideally as the first vasopressor, but certainly within a maximum of the first 6 hours. And we gave blinded infusions, and we titrated it up, if needed, to the 0.06. So if you had more severe shock, you could get a higher dose of vasopressin, comparing it to blinded infusion and norepinephrine. But again, you're familiar with the result, I'm sure. We found no difference in the primary outcome, which was the number of renal failure-free days, or counting up the number of days that you were alive without renal failure. There was no difference between the two groups. But interestingly, in our planned secondary outcomes, we saw a signal for less dialysis use, less renal replacement therapy in the patients who were randomized and given vasopressin. And you can see the absolute difference is nearly 10%, with the confidence intervals just below 0. So suggesting there may be an effect. It didn't seem to affect mortality, but did seem to be associated with less dialysis use. And that was supported by the sort of physiological measures. Again, looking at creatinine over time, you see it tended to be lower in the vasopressin in the blue boxes over time, and maybe some signal of increased urine output. And of course, renal replacement therapy wasn't protocolized in this trial. It was up to the physicians to decide when they gave it, because it was a blinded infusion, so they didn't know which arm the patients were in. But maybe they were seeing this lower creatinine, higher urine output, and weren't putting them on renal replacement therapy. Bringing the evidence from all the vasopressin trials together has been done just this year in JAMA. Not just septic shock, this was all vasodilatory shock. And so it includes patients who are post-cardiac surgery. And the primary outcome we looked in here was actually rates of atrial fibrillation. As we said, this sort of lower heart rate we see, the less arrhythmias. And you see there was a significant reduction in the rates of atrial fibrillation when patients are given vasopressin. So maybe this is one of the roles for this drug. Looking at other outcomes, renal replacement therapy, there's less data available, but a suggestion, again, in this, maybe there is less use of renal replacement therapy using vasopressin. But I think a note of caution, when you look at the adverse effects as well, digital ischemia, there is a consistent signal again. There seems to be more digital ischemia in the vasopressin-treated patients. So we have to weigh up all of these, I think, when we're making our clinical decisions at the bedside. But what about other vasopressin analogs, that was the title, it wasn't just vasopressin. Well, there are others you might want to consider. Synthetic analogs that exist, terlipressin and celipressin. And I'm going to talk briefly just about both of those. So terlipressin is more selective for the V1A receptors. Vasopressin binds equally to both receptors, whereas it's at least double the increased binding for the V1A with terlipressin. It also has a much longer half-life, generally several hours, compared to the few minutes that you give with vasopressin. So that's why you can give it as a bolus, although again other people have suggested giving it as infusions. The other more novel agent is celipressin, which is highly selective. It's made to be just binding to the V1A receptor. And its half-life is somewhere in between. In health, it's described as about 1.5 hours. In critically ill patients, it might be slightly longer. And remember, looking back at the table, these V2 receptors, as well as hanging on to the water, there was also this concern of factor VIII, von Willebrand factor, being released. And would these agents prevent that? Would they also lead to less water retention? And even some of the studies suggesting less vascular leak within patients with sepsis. So there could be an advantage. And there's just been published in Intensive Care Medicine, certainly online, a randomized controlled trial from China comparing terlipressin 20 to 160 mics per hour. It's actually quite a, when I was reading this, quite a high dose, but when you're working out per day, it is only it works out at 4 milligrams per day, which is maybe what you would use in hepatorenal syndromes, compared to norepinephrine. This trial was stopped early after just over 600 patients were recruited for futility. And the reason being their primary outcome was 28-day mortality, and you could see it was absolutely identical between the two groups. So they felt there was no chance of seeing a difference in terms of outcome. But again, safety is always important, and there were more serious adverse events in the terlipressin group. And particularly when you look at it, there was a really high rate of digital ischemia in the terlipressin-treated patients, going up to 12.6%, which is really high. In the VAS trial, it was 1 to 2%. In the VANISH trial, where we were using a higher dose, 0.06, we saw a slightly higher rate, up to 5%. So 12% is really high. Maybe it's just a dose effect, but I think this is an important signal we can see from this trial. In the editorial, we were invited to write for this. We did a little meta-analysis of the trials of terlipressin. You can see there's absolutely no signal for any difference in outcome. But again, far fewer patients have been studied compared to vasopressin. What about celipressin? Well, this new drug that developed, and in animal models here, you can see, compared to controls, norepinephrine-treated animals, these are not patients, sorry, I should have said, this animal model, celipressin-treated animals seem to do better than all the other treatments. It was then tried in early phase trials, really this phase 2A trial looking at dose finding, published in Critical Care last year. As you can see, the higher dose of 2.5 nanograms per kilo per minute seemed to be more effective at catecholamine sparing. And the reason people got excited is it did seem to be associated with less fluid, positive fluid balance, hanging on to less water. And we think that, well, maybe that would be advantageous. So that then led to the phase 3 trial, the Sepsis Act trial, which I'm sure some of you took part in, which unfortunately hasn't reported yet, but has finished. It's stopped. It's been terminated. When you go to the website, you can see it says it's terminated due to futility. And as far as I'm aware, it hasn't reported yet. So we await that trial. So in summary, I think vasopressin is a useful adjunctive vasopressor. I use norepinephrine as my first-line agent, but when that dose is going up, I think it makes sense to use vasopressin earlier rather than use it as a rescue therapy. Personally, I use it around about the 0.2 mics per kilo per minute norepinephrine. I've just been talking next door, and someone said that's a very low dose, but I think that corresponds to that 15 mics per minute that we saw in the FAST trial. And I think I do consider using it earlier if we're running into problems with tachycardia, arrhythmias, or if renal failure is developing. I think it makes sense to use it earlier rather than wait. I see no reason to use telepressin. I know not every country has vasopressin, and so therefore you don't have that choice. But if you have the choice, I think it makes sense to use the drug that has a shorter half-life, that we have more experience with. But if you have to use telepressin, be careful using high dose. Remember, it does have this long half-life, and so levels might accumulate, so be careful. And I think that telepressin, we have to wait for the full trial results as it's a new drug. I'm not sure we're going to be able to use it, but maybe we can learn some information from that trial about vasopressin analogues in general. Thank you very, very much for your time.
Excellent. Questions? Comments? So I will ask if you have the same thoughts that Flavia, if you have to combine with angiotensin II, how you make this cocktail of 3 vasopressors.
So obviously I didn't hear Flavia's talk because I was next door, but I'm not sure I would use all 3. I wouldn't use angiotensin II yet. I think the trial, I was talking about that next door. I said I think it's too early. It's a 300-patient trial, and although signals were, there was no safety signal and mortality was favoring the right way, there was a higher heart rate in the angiotensin II treated patients. Maybe that's not important, but maybe I think we need larger numbers before we use it routinely. So the cocktail I suggested to the audience next door was norepinephrine, then vasopressin, then hydrocortisone. And I think that covers most patients. And I don't want to start a hydrocortisone discussion at this stage.
No, but it is interesting discussion because Flavia spoke about hydrocortisone, but what is a good time for you to introduce hydrocortisone if you introduce hydrocortisone? I do.
Yeah. So I add it in generally after I've added in if I start the vasopressin at 0.2, and if the patient is looking great and now is better with that second agent added in, nothing to do. If they're not, that's when I add in the hydrocortisone then. Using the recent, the French study, Gilali's study, where the patients were much sicker than the adrenal study. So I think if the benefit is going to come, it's going to come to the patients on the high dose vasopressor. So I leave it for those sicker patients.